Good afternoon, everyone. Welcome to the March meeting of Plan, Design, and Expenditures. We'll just give a minute for everybody to get signed on. Looks like, Isabel, what do you think? It looks like we got...
Maybe just another minute or two to get everyone transitioned over to host duty.
Okay, I think I'm all set.
Okay, great. Thank you. Welcome, everybody, to the March and final meeting of the Plan, Design, and Expenditure Committee of the Universal Health Plan Governance Board. Let's get started with a roll call.
Yes, Helen Belanca.
Here.
Chunwei Chi.
Here.
Thank you. Peter Addy. Don't see Peter yet. Gabe Andine.
Hey!
Love it. Betsy Boyd Flynn.
I'm here.
Mike Durbin.
I'm here.
Rob Fizette. I don't see Rob. Tony German.
Present.
Thank you. Eve Gray.
Here.
Rosemary Hemmings. Don't see Rosemary yet. Julianne Horner.
Here.
Max Kaiser.
Here.
Jim McGee.
Here.
Thank you. Peter Merritt.
Here.
Angela McCallick.
Here.
Jamie Osborne.
Here.
Thank you. That's everybody.
Great. Well, before we dive into the agenda review, on behalf of the entire board, I just want to extend my deepest gratitude to all of you on this committee for your service to the board. We have tackled some really challenging topics in this committee, and your input, your expertise, your experience has been so valuable to us. And we deeply appreciate all of the time and effort you've put into this. Many of you, most of you, have done extra work outside of these meetings to contribute to our discussions. And we have found your input incredibly valuable. You've really influenced this work, and we're really appreciative. So thank you deeply from all of us. And I think I speak on behalf of the staff as well. It's been just a pleasure to work with all of you. Just looking at our agenda for today, after we get some updates from Director McDonald, we're going to have a couple of discussions today. One about workforce, one about cost containment strategies. And then we have a consideration from the operations committee regarding enrollment that they would like our input on. We're hoping to wrap it up with a review of all of the proposals from this committee that will go to the board and to be reconciled with the proposals from the other committees. So it's a pretty full agenda, and hopefully we will get through it and set you all free. Oh, I should also mention, we have mentioned this at the board and at the other committees, that technically, even though this committee ends after this meeting today, we've learned so much from all of you, and we have learned of your expertise. And we are hoping, if you are willing, that as the board moves forward into its final reconciliation and the final report, which is due in September, we would love to be able to call on you individually, both to provide written feedback on some of the reconciliation work that we're doing, or some of the adjusted proposals, or to provide public comment to the whole board regarding certain discussions. So even though the committee is ending, it doesn't necessarily mean your involvement is ending, of course, unless you want it to. But as we continue to sort of wrestle with some of these tough decisions, we're really hoping to still be able to lean on all of you And of course, feel free to decline if you're not able, but we really appreciate what you've been able to offer. Okay, at that, I'll turn it over to Mimi for an update.
All right. Thanks, everyone. So good afternoon. This is Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. And I definitely second Chair Belanca's absolute thanks to all the work that this committee has done. Myself and the staff are exceptionally grateful. I think you guys will be amazed at the very end when we go through all the proposals. There's just a significant body of work that this group has produced. So having said that, let's talk about what's been happening at the board and at the other committees. So at the last board meeting, the board reviewed kind of the timeline for the board work and also for the committees, which in addition to plan design and expenditures wrapping up this month, also the Finance and Revenue Committee will be wrapping up an Operations Committee. Kicking off will be the Transitions Committee, which will be exciting, and Community Engagement and Communications, which had been on a little bit of a pause just with their meetings, not so much the work, that will be starting back up again in March. And if people haven't heard, the Community Engagement and Communications Committee has switched their time. So they will be having meetings that start at 4 p.m. and go all the way to 6:30 p.m. with a very specific time slot between 5 and 6 to enable time for public comment. Kind of jumped ahead a little bit there because I was so excited about that. But it's kind of one of the things that the board was talking about at the last board meeting. We did a in-depth review again of the Milliman expenditure, which this group is very, very familiar with. Dr. Chun-Wei Chi gave a presentation on international universal health plan efforts, which was terrific, and a lot from his experience that he'd been at the last 2 international conferences that he was able to attend. The board saw the subrogation proposal and an enrollment proposal, and also the behavioral health payment proposal that came forth. At the Finance and Revenue Committee, they are wrapping up the operating revenue strategy and also their reserves revenue strategy. So that final meeting is going to be on March 17th. The work will not stop on that date, though. There will, be ongoing adjustments to the revenue proposal and the revenue strategy as the board looks at it more. Next, on operations, I had a great informative presentation from Lee Hastings about federal health plans and how they will be able to interact with the Universal Health Plan and develop some recommendations around that. So think about things like the VA or TRICARE. And then also continued investigation into information technology systems. We did a deeper dive into what's happening in Washington with their efforts around developing a kind of a platform, an electronic health record platform that includes the people who are on Medicaid, but also includes those who are served by the DHS in Washington State and folks who are in the carceral system. It's really exciting, and that's like a multi-year proposal. So that was really interesting to take a deeper dive into that and see how it might influence the things that we're thinking about. CECC, already talked about. In addition to the committee work happening, the targeted strategic engagement meetings are happening this month. There's a lot of excitement, a lot of work that goes out about that. But what's happening is all of sort of the details of the preliminary proposal are going out to these smaller groups that have been really thoughtfully put together, and we'll be hearing back for them. And I think that's going to be very exciting. And all that information will be coming back to the board in April. So it's going to be exciting. And then Transition Committee, as I mentioned, the charter was approved, committee members approved, and the kickoff meeting is on March 19th. So that was a lot. I'll pause here for a second for any questions or any additions from board members. All right, I don't see anyone, so we're just going to keep moving. And I am going to turn it over to Lee Hastings.
All right, thank you so much. So I'm going to talk a little bit about workforce considerations. This was something that was on PD&E's original work plan. In addition, we do have this particular charge that you can see in the little call it box on the left here. That is part of our statute that does ask us to both be engaging with regional organizations related to these kind of topics, but to specifically take a look at strategies to reduce complexities and administrative burdens for participants in the healthcare workforce and otherwise address workforce challenges. So in response to this particular charge, we have drafted a memo. I don't believe it's fully available yet because since the bulk of it is related to that administrative element, that is going to be part of the operations committee. I would strongly suggest if this is a topic that interests you, please do attend that operations meeting the last week of the month. But of course, we did want to share some of the broader workforce challenges with this group. And that memo outline, as you can see, addressing those sources of complexity and administrative burden, some strategies there, broader healthcare workforce challenges, and finally, implications for the board work. We're really just going to focus on that third bullet here. Next slide, please. So just beginning with a really narrow focus on what the primary care workforce looks like. And you're going to see a lot of numbers in this presentation. And I'll be honest, from slide to slide, those numbers can be different because a lot of different sources have different ways of counting this. And having spoken to, or gotten feedback from a couple of the subject matter experts on this committee, they attest as well to the fact that data is just really difficult to find when it comes to workforce. So just understand that and know that these are kind of more suggestive figures than necessarily being hard and fast. However, we can see from some national data that concerns about primary care workforce are not just confined to Oregon. We see that overall folks estimate that the demand for primary care services is going to increase by margins that exceed what current pipelines can produce by about a 5% differential there, seeing an increase of 14%, and the supply can only increase by about 9% with our current system here. Oregon proportionally has a smaller number of primary care medical residents. And so this is specifically speaking to residents, folks that are in training based on those various specialties than what we see nationwide. So here we only have about 11.7 per 100,000 as compared to nationwide at 17 per 100,000. As some of the other data will show, we end up doing okay, but Oregon really relies pretty heavily on in-migration in order to sustain its primary care workforce. That's really the main takeaway from that particular piece. On the right-hand side, you can see this is what our primary care workforce looks like today. And what's really interesting and great is that OHA is able to kind of show the difference between the numbers that are actively practicing and then what that translates into for an FTE or a full-time equivalent. So recognizing that not all primary care practitioners are necessarily working a full week. They might be doing an 80% or even a 50% kind of week. All right. So when we look at those practicing physicians per capita, and like I said, some of the data is going to jump around here. What's notable about this number is we are talking all physicians at this point. So there is no way to kind of dive in and see that primary care number. But on the surface, Oregon actually compares very favorably to other states across the US in terms of the number of physicians per 1,000 people, which is sort of the standard metric that's used. We sit at around 2.74, which is one of the highest across all 50 states. And it is higher than our neighbors both to the north and south, Washington and California. However, just because we're performing well by US standards does not mean that we should congratulate ourselves too much, because if you do look at other kind of highly developed nations, you see that their average is still fairly significantly above ours, an additional 1 physician per 1,000 people, around 3.7. Next slide. Now, of course, it's impossible to talk about workforce without mentioning that rural communities in particular face very real challenges. So this graphic was created by the Oregon Office of Rural Health, and there's a few different ways to take this, but essentially, as you look at this graphic, what they have done is they have determined kind of what the, supply versus demand looks like across the state. And if an area is noted in white, it means that it's above that median level. If it is shaded, it means that it is below that. And of course, those correspond very strongly to those rural regions. Those that are in the darker shades, the blue, for instance, I think there's about 7 of them, 11 primary care service areas, in fact, that appear as the blue. Those are what we would term a primary care desert, where they actually do not have any practicing providers in those areas, and so folks have to travel. So the Office of Rural Health estimates a pretty even ratio of supply to demand if, and this is a big if, one were to theoretically spread all of these folks across the state in accordance with population. However, when you look at those rural and remote regions as compared to urban, there's a real skew where there's a ratio of 0.71, indicating there is quite a bit higher demand in those rural regions for these folks than the supply is able to meet. All right, so in that memo, I did summarize quite a bit of the literature that's out there, and it really coalesced around these kind of 4 strategies that are commonly cited as ways to address these workforce challenges. So first, of course, the training capacity and pipeline expansion, really looking at the long-term, sustainability of this, making sure that there are ways to get more folks trained, and in particular, to get them trained in more rural and community-based settings where that need is so much higher. So this can also include things like scholarships and stipends that are tied to particular service commitments. That's something that frequently comes up within that sort of category. Second big category, and this gets talked about quite a bit in the memo since we do have that focus on the administrative burden per the statute, but looking at improving the retention of our healthcare workforce. We know that healthcare workforce has much higher rates of burnout than are experienced in other industries, and there are a myriad of reasons for that, but we know that working conditions can be difficult, particularly in certain settings such as hospitals. Behavioral healthcare providers are kind of at the top of having some difficult working conditions. And then that administrative burden piece is, it's non-trivial. Absolutely, the amount of time that we ask our clinicians to spend documenting things and doing essentially non-patient care work really is a very, very strong contributor. So a lot of strategies focus on that. This is particularly notable given kind of our charge looking at designing what a universal health plan could look like. This is, just the big area of opportunity from my perspective in terms of being able to really streamline those requirements, create a unified standard for what documentation is required, and cutting down all of that, I'll just call it administrative waste, even though it's not waste the way we would think about it, but that time that gets really derailed from patient care into these administrative tasks. So being able to direct more clinician time to patient care could go a long way towards even just helping with some of the workforce issues that we see. Additionally, financial incentives. So this is typically seen in the context of really trying to get folks out to those rural and remote settings where there are retention bonuses, stipends, tax credits, etc. And Oregon has several of these programs in place. And then, excuse me. And then finally, what we have are scope of practice and team-based care models. And this, somewhat similar to what we see on the administrative burden side, is a lot about improving kind of the quality of the experience, as well as letting, that clinician time count for as much as possible. So by using those team-based models of care, they can really, get folks to work at the highest level of their license, and in that sense, expand capacity without necessarily needing more people, but by using the skills that these folks are trained for in the most efficient and effective way possible. Next slide, please. So of course, I did not want to leave the impression that Oregon's not doing anything. We have so many boards and work groups that are focused on this through the Oregon Health Authority. So I found this table to be a particularly good summary of a lot of the programs that are currently out there. This is from their 2025 evaluation report, which does note that these programs do demonstrate success in getting folks to work in rural settings, and in particular to stay in those rural settings, which shows a lot of promise that folks do tend to stay in those settings even after, their initial contract term has expired. So, these are definitely things that work and things that, Oregon is working on and has in place. And that is that. And I've seen a lot of discussion in the chat. I know we have several experts, so I'm just going to open it up for discussion.
Lee, I'll get started. Did you come across any, I know you said that we depend a lot on drawing primary care providers to Oregon from other states. What works for that? Like how, like I'm under the impression, I think it's correct that primary care is lacking sort of everywhere. And so if we're relying on drawing primary care here from other states, are there states that do better with this than others? Have you come across anything like that? Like what is it that attracts primary care providers to leave their state and practice elsewhere?
That's a really great question. I didn't look at it quite from that angle, but I did find repeated references to the fact, both for primary care generally and for nursing as well, that we do rely heavily on in-migration. And maybe it's just because, Oregon's a great place to live, but we've been very lucky in that respect. Though I would have to go specifically look for comparators to, I think, get to the heart of your question.
What do other folks think about that? I know we've got Betsy and
yeah, Jamie has her hand up.
But yeah, go ahead.
Sure. I have to leave in just a moment to attend another meeting about this issue, but I'll be back. I would say just our experience in Southern Oregon is that we created a way for all of us to recruit together as a community to draw providers in, and that has been successful. The most recent is a husband and wife primary care powerhouse team that moved here from South Carolina. And they said everything about Medicaid here is better than where we came from. Everything about the rural challenges that we experienced in the state we came from are better here, even though they're not perfect. And so I think having a well-designed universal health plan is really going to create some incentive for in-migration for providers who are sick of the moral injury that they're experiencing in other places. If we can lighten that, they will come here. Yes, and it's beautiful.
That's great. Yeah, thanks, Jamie.
And Eve.
Betsy was first.
Oh, if you're talking, Eve, I think you're on mute.
Oh,
there we go.
I was going to say, I think Betsy was before me. I didn't want to jump in line.
Oh, sorry.
Thanks. I was just popping out to get the link to SOAP, which is what Jamie was talking about. Yeah, so I think Oregon has I think Jamie's spot on, and I think that the other thing to bear in mind is that we have greatly expanded the capacity of to train family physicians or primary care physicians, family physicians specifically in the state in the last 5 years. And that infrastructure, those training slots need support and reinforcement. It's a pretty well accepted statistic that physicians generally stay within 300 miles of where they train. And for rurally trained physicians, it's even smaller, like within 100 or 50 miles. So the more people you can train in the places where you need them, the more likely you are to keep them. And I just wanted to point out too that, to Lee's point about what is a successful recruiting we're about to see a live experiment with that in all 50 states as they implement the rural health training program funds, because most states are going to take advantage of some of those dollars to try to recruit more primary care clinicians. And so we will be seeing how those efforts play out, and potentially hopefully learning things that we might adapt ourselves, or watching our members, watching our doctors get poached. I don't know. Hopefully folks will stay. I mean, my counterpart in Missouri was saying that his idea was they were just going to give everybody $100,000 to move to rural Missouri to buy a house. And in rural Missouri, $100,000 will get you pretty close to
Wow.
a fat equity in a pretty nice house.
Betsy, do you know offhand how many family medicine residency spots we currently have in Oregon, like first year spots?
Yeah, I can pull that while we're on the call. My understanding is we are producing 54 per year. We are graduating 54 new docs per year.
That's a lot more than when I did residency. Wow, 54 a year. That's pretty good. And then we have sort of new residency in rural residency program in Hood River, right?
Yeah, the newest program, the newest site is in Madras. It's the Three Sisters program. It's affiliated with OHSU. They have not yet graduated their first cohort. But we have 9 sites now across the state, including a rural training track site on the coast that's part of Samaritan and Newport. Roseburg, which is a teaching health center residency based in a community health clinic at FQHC. Klamath Falls is a venerable program and produces a lot of folks. Providence Hood River is a rural training program. It's a little bit of a different animal, but they're still producing folks. And we have a newer program in Hillsborough that's a full program that's affiliated with OHSU.
That's fabulous. That's
I'm sure
really
we're
great.
missing something, but yeah, so it's great. They have been ramping up, and we're very excited about that. And I am a little worried about I am also hearing that circumstances in some of the residencies are a little more shaky, as their systems are shaky too. So I don't think we should necessarily presume that we will keep this unless we fight for it. So I'll give you those exact numbers in just a second.
Well, here in Lane County, we live in a residency desert. So we are a ridiculously large community to not have access to a residency. We have 2 hospitals and multiple health systems, and we've just never been able to get someone who had the resources to invest to really get a residency program off the ground. I do think that additional support from, in terms of the creation of, the management of, the oversight of a residency program could be helpful in our community for sure. And it is, in-migration is sort of great, but often it is exactly the example Jamie gave. You've got 2 people who need jobs, and you have to have those 2 jobs available in your community, and you might get together with partnerships and you might be able to cobble it together, but a lot of times we actually can't cobble it together, especially if the spouse is not a physician. Let's say the spouse is a chemist or some other type of profession, and we just don't have that within our community. So it is much better to be able to train our own whenever that's possible. The programs that we have that help with reimbursement of loans, loan forgiveness programs, they're very effective and are, just as the data that Lee presented, our providers tend to stay even beyond the point where those are paid off. So that is very helpful. Better yet would be to subsidize the education so that folks don't come out with those loans in the first place. But that's the next best thing. And we have also shortages, physicians are one part of that, and we have shortages across health professions. So really continuing to think about how we build clinical programs to train professionals. I think the burnout piece has eluded me more. I mean, yes, if we could get people to burn out less and to work a 1.0 FTE, that would be great. But I don't know that I see us getting from here to there, even in a universal health plan model. There's just such a huge demand and so much moral injury, and people have lives and they have families, and working 40 hours is not working 40 hours as a provider. You tend to have work outside of your work, and so I think the burnout piece is a harder nut to crack. It's easier to talk about training new people, but that's the more expensive option as well.
I think Gabe, you were next, and then Chunwei.
Thanks. Yeah, I appreciate all of this. I just want to add a couple pieces. I really appreciated, Lee, the diagram you had about the rural workforce shortage areas, and what everyone else has had to say about the incentive programs we have to attract people to work in Oregon, and particularly in rural settings. And it's nice, it's great to hear that those work sometimes beyond the 2 or 3 year sort of commitment time frame. There's a lot of research out there. This has been studied for decades. It's well known that one of the best predictors of what type of student will wind up being willing and interested to work in a rural setting and to stay in that rural setting is looking at the setting that they grew up in. And to that effect, Oregon, like all other states, has an organization called the Area Health Education Centers that has a program office based in Portland and regional centers around the state that work for the whole pipeline, starting in high school and sometimes even before that, with programming to attract and cultivate interest in not just medical or even primary care workforce, but the entire healthcare workforce, to expose students early in their educational pathways from those rural settings to careers like this, and to provide mentorship throughout their educational pathway, starting in high school, like I said, going through undergraduate and then to graduate school, and even beyond that to help with placement. So that's a really robust piece of infrastructure that we, like a lot of other states, have, that I think is important to be aware of as a resource. Again, not just for primary care or for physicians or family practice, but for all the other important players of our healthcare workforce that I think we as a board or as a committee and the board need to be sort of focused on cultivating the entire spectrum of our healthcare workforce. Thanks.
Yeah, Chunwei, please.
Yes, thank you. I think in terms of recruitment and retention for primary care workforce in general and for all workforce particularly, there are regional, particularly rural conditions and challenges that can vary from region to region. But at the same time, I think from the board's perspective, we need to find out and collect information on what are the major structural factors affecting retention and recruitment. So for example, where I live, the Benton County, over the last 2 years, we continue to lose primary care physicians. And one of the factors, among others, is the equity firms' control and ownership. And the equity firms' control and ownership is not limited to Benton County, it's nationwide. So this is just one example. We need to identify what are the factors that put Oregon in general in disadvantage in terms of practicing environment. And by identifying those environment, then when we design our delivery system, we can be more targeted. The education part is very important, but I suspect from the board's perspective, we may have very little influence on the education training part. what we can do from the universal health plan's perspective is how to develop the environment that's appealing and attracting primary care physician to come and to stay. And for example, how can we, well, once we implemented the universal health plan, the administrative burden will surely be dramatically reduced. And then we also need to communicate that both in the purpose of retention, but also recruitment. And another issue that's probably beyond this topic, but we also need to consider related to primary care, is once the universal health plan is implemented, we are still going to see areas that are severely lacking primary care physicians. How do we, as the universal health plan, address that issue, such as developing alternative delivery mode, either a combination of online and in-person, or a mobile unit, or other creative method to address? Because one of my major concern, once the universal health plan is implemented, is in some region where there's a lack of primary care physicians, people have coverage but no services. So that's we have to design and plan ahead of time. Thank you.
Thank you. I think Betsy and then Tony.
Yeah, if I can just thank you, Dr. Chia, if I could just sort of emphasize what you just said. I think this is really important to consider. And I'll articulate this the best that I can. We believe the evidence shows that a medical home, a team-based medical home that delivers advanced primary care is the best model to shoot for. And that our patient-centered primary care home program really has been a national leader and continues to sort of set that standard very, very clearly. And we have nothing close to the capacity to care for every Oregonian in such a clinic. And so the variables that will confound this work are also potentially exciting, right? We don't know what visits ought to look like in 15 years, if they're augmented by AI, or if the implementation of a care team means that the clinician, the physician, the senior clinician, whomever that might be in the clinic, is seeing patients less often than they are doing population health management stuff, for example. You know, there are people who theorize that the one clinician, one patient model, you know, all day long is not sufficient to deal with what we've got, what we need to do. I don't know that I agree with that at this moment, but I think that it's probably important that we articulate the gap between what we think is ideal and where we are, and how we are going to get there, you know, incrementally. To say something like we have to recruit 100 more doctors per year, or 100 more full-time PCPs per year to be able to get to where we want to go. Because I think that we have sort of vaguely been saying it's not enough, we're in shortage, a crisis is coming, we need more, without actually putting hard targets and acknowledging that if we are in shortage, what does that mean and how do we best manage that shortage? I hope that was semi-articulate.
Oh, that was great, Betsy. I actually agree with all the comments. Promoting good programs. Gabe, yes, we need to do that with AHAC. I did have a question for actually Dr. Chi, and thinking, you know, in a single payer, funding streams in certain sectors, what we have is a misallocation of incentives, and largely that's driven is if the healthcare system there locally can make money. In a centralized system, you could say, hey, in Eastern Oregon, in this region, we see this need. Therefore, we're going to allocate more resources in that setting, particularly for a hospital. We see this just in Ashland as far as a hospital closure, because that's no longer appropriate to maintain the budget of that area. But if it is a resource, I'm just curious how Taiwan has emphasize in shifting some budgets to make sure that in lower resource areas or challenges there, that there has been some shifting of funding to make sure that is more equitable access. And And maybe that's another whole presentation, things like that, but I think it is pertinent to this conversation.
Thank you, Tony. Yes, Taiwan's universal health care over the last 4 decades has continued. They are very sensitive in assessing people's access. So they have, over the 4 decades, developed various innovative ideas. In terms of resource reallocation, yes, they reallocate extra budget to area where there's a shortage of physicians. And that budget includes subsidy for the clinics that require additional equipment. And another program they did was to have a regional teaching hospital team up with more rural remote clinics and doctor's office as a support. And so those individual, particularly the rural area individual clinics with those support program, they get teamwork. They're not just working alone. And last year, when I attended one of the 2 international conferences regarding the new innovation, so Taiwan now is very actively building up the AI support. And this is one of the innovation and alternative delivery mode I mentioned earlier in my comment, that for area that has a shortage of clinics, for example, 2/3 of Taiwan are mountains, and there are people living in those mountain areas. They are very sparsely populated, and it's not practical to have clinic on those mountains. And so for non-urgency care, the National Health Insurance try to link those people living in very remote mountain area with online access to non-urgent consultations through the support of physician in the city, but also through the AI. So this is just one example. So a centralized universal healthcare system have all those leverages and options from technology to resource reallocation to address those issues.
Eve.
Okay, now I'm going to take us down a real rabbit hole, but Dr. Chi, I appreciate your comments and part of that in terms of having the leverage to utilize, for example, like AI tools, is that I'm assuming they're on one medical record or one health record. I don't know that to be true.
Yes. Taiwan, I think, probably has the world's most advanced health information system under the universal health care. And that's something we need to develop along the way. That health information system goes 2 ways. One is for the provider, the other is for every citizen, every resident. And so it's a unified record. It's a cloud-served unified record. Individual person can access their own health record or test result, etc. At the same time, all contracted providers, that's more than 99% of clinicians and hospital, all contracted providers, they can easily access their patients' record on the cloud. And those information technology serve multiple purposes. It both improve the quality of care and improve patients' health promotion education, but also another important function is reduce the cost, because those cloud information and unified patient record dramatically reduce the redundancy of tests, particularly the diagnostic imaging tests, but also prevent redundant prescription drug, because Taiwan, the universal healthcare has kind of unlimited access. Patient can just go to any contracted providers. And before this, the cloud system established in 2013, before that, there's a lot of redundancy in both testing and prescription drugs. And so, yes, a highly effective information system is an important core to both improve access, quality of care, but also control costs. Also, another advantage of that same information system is Taiwan has probably one of the fastest claim reimbursement. Taiwan started online submission of claim around 2002. And at that time, the early incentive is for providers, if they submit their claim to the National Health Insurance Administration, they were guaranteed to get payment within 15 days. But if they submit the traditional paper, by now, no one submit paper. It's all online. This was at the beginning, 2002. So for people who still submit paper, they will wait about a month. So that's an incentive to encourage all providers to use their online system.
All of those are really great points and things that we should think about crafting into, you know, I think this is something where we got to get something off the ground to start. And then we have to engage in continuous improvement to create the system that we actually want. But this piece around health information technology, ability to communicate across the system and within the system, we've got to figure out how to get from here to there, I think, for this system to be as successful as we hope.
Yeah, and I think Peter has his hand up. Peter.
Yeah, thanks. I used to work at the VA, which is the largest integrated healthcare system in the country, that I was always told anyway. And it's really great to be able to see the reduced redundancies and just a lot of the abilities that are available if people are moving, but the doctors stay put. You don't have to start over all over the place. And what I was just hearing about Taiwan system and doing things for decades, that's all possible without AI. I said this last time, I'll say it again this time, the environmental destruction that AI causes outweighs any potential healthcare benefits. You're destroying people's health in order to provide better healthcare. It's just not a good system. So if we're going to do this piecemeal, as Eve just mentioned, just get something off the ground right now. No AI. If you want to reconsider that in a decade, if we're still around in a decade, that's great. But at this point in time, AI is not good for our health on a population level. Thanks.
I'll just jump in here and say, yeah, thank you for all your comments on that. I think the role of IT in a universal health plan is really critical, as Chun-Wei alluded to. It's half of what makes it work. And we know that we're not going to be able to cover all of the pieces that would need to happen for a universal health plan with the work of this board, even between now and September. And what we've been working on as a board is sort of a continuation plan for the 2027 to 2029 biennium. And a big part of that continuation plan will be sorting out the IT needs and really diving into that topic specifically to say what would that take. So yeah, I appreciate all the comments here, and we're hoping to look into that more in our next iteration of this work.
I just want to give a quick comment related to Peter's comment. Yes, Taiwan was able to implement very highly sophisticated and effective information system for 2 decades without AI. Yes, it is feasible to do that without AI. And also the information system will be very important, and we can build stage by stage. For example, Taiwan's information system is also vital for enrollment, because you need to have every resident's information data in the system. And from the beginning, the enrollment itself also require that information system. And I have a suggestion that the board may consider that when we are proposing the future AI system, IT system, information technology system for the universal health plan, we might use Taiwan's system as a template, and we may not be able to get there in one jump, but that as a kind of phasing model we can consider.
Yeah, thank you, Chun. I appreciate that. So in terms of workforce, we won't have a specific proposal to the board, but more sort of an iteration of the ideas and success stories. And as many of you have mentioned, what we know from research works to draw clinicians. So I think we're just going to use all of that information and sort of be an informational part, but we don't have a specific recommendation to the board on that. But we appreciate your input, because I think talking about it as part of our report is really crucial. We need to reference our thoughts on that. So that's great. Thank you. So let's shift gears a little bit now and go to cost containment. Pass it over to Lee.
All right. So we discussed this last time, so we're really just revisiting at this point. Let's jump forward. So we had talked about a number of different strategies and asked for some input. Unfortunately, we didn't get a whole lot of feedback, but this is what we did receive. Wanted to present kind of another way to think about it, as we're looking more for kind of high-level direction from this group about how should a universal health plan really think about cost containment strategies. I think we can all agree everything on this list could work, whether you think it's not a good strategy. They've all been demonstrated to work, but we're really looking for, okay, how do we prioritize these? And this is very short, so Jim, I am just going to wait on that comment. Next slide, please. All right, so as I was reviewing these and thinking about them, I really felt that they generally fell into about these 3 strategy categories. So this is how I wanted us to kind of think about it today, knowing, of course, that some of these strategies really, kind of straddle some of the categories. But just for the sake of clarity, I put them into these 3 buckets. We have those categories that are really, or those strategies rather, that are really at the system level. So looking just across what kind of efficiencies can be achieved there. Others that are really focused on providers and provider experience, and then another big chunk related to pharmaceuticals. And the 2 pieces that I thought might be useful for framing, and I'm certainly open to other suggestions if folks have them, but really looking at impact, and this is compared to the status quo. So understanding that some of these strategies do already exist, we're really looking at what is going to move the needle, what's not just kind of a continuation of like, we do this and, we continue doing it, but what is really going to drive some meaningful change in cost containment, as well as timeline, wanting to understand what is, as a former colleague of mine used to say, all the low-hanging fruit, what can get us those early wins, and what are things that, are going to maybe take some time, because having probably, I would say, a mix of those that are both short and long-term strategies is going to be best for the overall sustainability of this, since we are looking on a long scale, but we are going to have some significant upfront costs here. Next slide. So looking at those system strategies, I really grouped 4 in here. There was that enforcement mechanism for exceeding the sustainable cost growth. Notably, of the folks that did send feedback, nobody was in favor of this. So that might be one that we just want to, go ahead and ignore here. Also consolidating state purchasing, both of pharmaceuticals and DME, engaging in fraud protection, and then prioritizing the family medicine pipeline, which I'll note just had 1 vote. Another person mostly just indicated they weren't sure how this tied directly to cost containment. So that one, potentially in there, but a little more ancillary perhaps. And we'll just move forward because I know Jim is also going to present some suggestions here. So the next category really related to those provider process and payment strategies, kind of middling support for these. We have, of course, the global budgets. This could be applied to segments of the healthcare population, so it doesn't need to be just one kind of provider, but it could be done in many different ways. Looking at that administratively streamlined prior authorizations, as well as I think other administrative simplifications could probably be grouped in there. A universal fee schedule, and then implementing those standards of care. So things that are really designed to get at how providers do things or how providers are reimbursed. Next slide. And then, of course, quite a bit under prescription drugs, thanks to our partners here at DCBS that do so much work on prescription drugs. So we really pulled from them for a lot of this, but ensuring that programs are prioritizing the use of generics over brand names. We saw previously what a difference there is in the cost of those two types. Mitigating any sort of manufacturer steering of patients towards brand names. So related that upper payment limits, not one that seemed to garner a lot of support. Tiered pharmaceutical pricing, kind of in the middle there, and then sort of a last minute addition that there seemed to be some interest in continuing to explore is looking at strategies related to specialty drugs, which account for a very small percentage of the market, but are the most expensive category of drugs. And we're not actually going to be, I think, doing the discussion and vote because we do have another presentation here. Jim, I think you did have a comment. I don't know if you want to ask a question.
No, I just didn't want to have a vote before I got a chance to
Absolutely
say my
not.
piece.
No, I just didn't get a chance to update those slides. So I'll turn it over to you for your discussion.
All right. Are you going to advance the slides?
Yep, I'll take care of it, Jim. Thanks.
Okay. So basically, I'm approaching this from perspective of somebody who has been in the employee health plan space for my entire career, specifically labor management plans, both public sector and private sector. But also I spent 6 or 7 years working with the Pennsylvania Healthcare Cost Containment Council, which was one of the first public state data agencies to issue report cards on doctors and hospitals. And then when I moved to Maryland, I got involved with the HSCRC, which is the rate setting agency in Maryland that sets rates for Maryland, and in 2014 moved to global budgeting. That's what informs my perspective. Number of years ago, I took a deep dive into the Institute of Medicine report on waste in the healthcare system that resulted in presentations to our professional organization and also an article in Benefits Magazine. And you can move forward. Oh, I guess I did that backwards. So basically what my take is that the cost, how we normally think of cost containment has been largely shaped by the private benefit space, which is, in my mind, totally ineffective and puts patients in the middle in a number of ways. And that we can achieve the desired savings that we're looking for by looking at many of the things that were talked in the earlier discussion today, which is redesigning the delivery of care. So in the near term, I think we need to rethink about what our data needs are, design impact areas and develop pilot programs around them, and also start thinking about designing programs to address the social determinants of health. One of the things that came out in the Institute of Medicine report is they cited numerous examples of hospitals and community organizations collaborating to address specific social determinants of health in a community. For example, asthma or back pain that eventually in our fee-for-service arrangement got shut down by the hospitals because they were losing revenue. So, you know, we need to think about how financial incentives distort what we're trying to achieve. Next slide. Oh, next slide. We already did this one. So I mentioned before, current employer-based plans, they don't have the market power to affect prices. They rely on strategies that put the patient in the middle. They shift costs. They create narrow networks. Each insurance carrier develops their own standards of care, which creates prior authorization burdens. And there's been a lot of talk about consumerism and skin in the game, and that this would encourage patients to affect change. In fact, that was the whole reason why the Pennsylvania Healthcare Cost Containment Council was created. They felt that it was actually background on that. The Pennsylvania Healthcare Cost Containment Council is an independent agency that has 6 representatives from the business community and 6 representatives from labor. And when it was originally created, 5 representatives from the rest of the industry, because they felt that purchasers, as defined by business and labor, if they had better information, could make better decisions. I think that was a flawed assumption in hindsight, but you know, it was an interesting perspective. No less an expert than Consumers Union did a report on consumerism in healthcare and determined that only 7% of services are meaningfully impacted by consumer decisions, that consumer decisions are largely physician directed, which is why I'm arguing that the real opportunities for cost savings is in system redesign, which is all the things that you were talking about before you listened to me. Next slide. So this is from that Institute of Medicine report, and it basically said that 30% of healthcare spend is wasted, and it broke it down into these categories. And look at about half of it is inefficient services, unnecessary services, and misprevention opportunities. Next slide. One of the things that was instructive when I was working at the Pennsylvania Healthcare Cost Containment Council, PHC4, before we did our report card reports, we were doing a lot of stuff looking at variations. And what you find is, and this work follows on the work of Jack Wenberg, if anybody's familiar with him, where he developed the term country club medicine. The practice patterns are very regionally determined. And by looking at variations in certain procedures, you can impact the health care. So if you can design systems that look at these variations, for example, in Pennsylvania, you had the city of Allentown who had rates of tonsillectomies that were off the chart, but very few colonoscopies, not colonoscopies, prostatectomies. And Reading, the city of Reading, which is like 30 miles down the road, it was exact opposite. And why is it that these variations exist, and understanding these variations? And Wenberg did a lot talking about what it was like communicating with physicians about this data. It's basically, it was his life's work. But reducing practice variations, developing standard clinical pathways, in my mind, those kinds of strategies obviate the need for prior authorizations. If physicians understand what's expected of them, they don't need to, or there's less need for prior authorization. Next slide. Again, this is the summary. The emphasis is on the process of care. It's on outcomes. It's on real-time analytics. Some of the things, again, you were talking about before I got here. And aligning incentives so that it's aligned for quality and not quantity. And key to that is participation in the provider community, because if providers don't understand what they're being judged on, then they're not going to be happy campers. Next slide. This is talking about the data sources. We've just had a discussion about electronic health records, admission, discharge, and transfer information. I don't talk too much about pharmacy in this presentation, although I probably have some opinions on it. But I think the key is understanding practice patterns, developing NICL guidelines, developing risk adjustments and quality metrics, and focusing on the delivery of care. Next slide. Yeah, these are just a couple of the additional details. Next slide. So again, this is looking back at, we've had some discussions in our group about fee-for-service versus global budgeting versus capitation. But in thinking about fee-for-service, it's kind of key how you define the service. And the more narrowly you define the service, the more opportunity there is to kind of game the system for quantity rather than quality. So anybody who's familiar with the DRG system knows that if you get enough ICD-9 codes in there, that you can get a higher reimbursement DRG. But if you have a category, for example, maternity, that includes all maternity deliveries, how might that incentivize, because in this country, we have a very high rate of C-sections. How might a broader definition of that service impact the delivery of maternal services? I'm going to tell a story on the operational performance metrics. We came out with our report card on cardiac surgeons. And shortly after we did that, I was delivering a presentation at Presbyterian Hospital in Philadelphia describing, the kinds of data we collect and whatnot. And somebody came up to me afterwards, a physician from another hospital in Philadelphia. And he said, don't listen to the doctors who tell you your data is junk, because that's always the provider, they always have caveats about the data. So we have somebody on our staff who was on the cover of Philadelphia Magazine is the best cardiac surgeon in Philadelphia. But he has lost his edge, and he was like one case away from getting a negative rating in our report card. He said, we finally convinced him to take an administrative position based on your data. So the key thing there is having validity in the physician community with the data that you're reporting on. I saw, now I'm going to talk about Maryland, two things in Maryland. One, they have global budgeting. And I think I saw, that it was suggested, or I'm suggesting rather, Maryland started off doing global budgeting with the sole community hospitals in rural areas because they didn't have to worry about migration, losing traffic to another hospital. So I throw that out as an example of something that might be tried. The other thing that Maryland has is, and I don't understand it well enough to talk competently about it, but they do have a state-sponsored electronic health record that is on the physician desktops, and I've actually seen it at my physician's office. It's not easily accessible, but it shares primarily pharmacy data and image data, which is one of the was mentioned in earlier discussions, unnecessary tests because you can't access the test results that somebody else did. I learned that from personal experience from a bicycle accident I was involved in. Next slide. Oh, there they are. I just repeated myself. So next slide. So basically what I'm saying is let's build a system that is focused on improving clinical outcomes and clinical performance. And let's not stick the patient in the middle of our efforts to manage costs because we don't know what else to do. And the other important thing that I kind of threw in almost as an afterthought is, this relies heavily on information technology. And there's a lot coming out now about insurance companies using AI to deny claims. And I want to make it clear that to the extent that this kind of system relies on AI or information technology, it's not to make decisions about healthcare, but rather to understand better the decisions that are made to improve those decisions. That's it.
Thanks, Jim.
I'm wondering, Chair, if yeah, thank you so much, Jim. If we can go back to some of the questions or the grouping that you brought up, either if this committee would be interested in maybe trying to do some prioritizing or areas where this group thinks that the really turning our attention and our focus on some areas as we are, working towards really trying to get the best, cost reduction, cost containment. If you want to do that by looking over your slides, or if you have other suggestions about how to get the conversation moving towards something that that might be helpful to bring in front of the board, as opposed to just sort of a list of these are all the efforts, because I am certain that people have opinions in this group.
I think you're, for the most part, I think those items that you put up there to vote on are valid considerations. The only one I take exception to is the use of PBMs, but
Yeah, I'll leave it to you, Lee, to think about how to navigate this.
Yeah, I'm not sure what the committee would prefer. I am prepared to kind of pull up the PowerPoint if folks want to kind of live do some prioritization or fill out the grid. That was kind of what my thinking had been, but also Chair Belanca, I want to be respectful of the timeline and accomplishing everything we need for today's meeting.
Yeah, I think we should, have a little bit of input on that. I really like how you laid out with system strategies and providers and pharmaceuticals. And I think, yeah, so let me have to put my glasses on, sorry. So with the system strategies, that one that you just had up, I mean, I guess I would just open it up to say, did we miss anything here? The fraud prevention is really important, but as Jim brought up in his presentation, I think waste and redundancy. And Chunwei also mentioned redundancy as a really key factor in this. So, I mean, I think those all could be together, but basically fraud, waste, and redundancy as a category. That would be my only addition to this. That's such a big part of it. But, so if anybody else has comments on things that are missing from overall system strategies for cost containment, so, go ahead, Jim.
I'd just like to make one comment on fraud. So it's my understanding that fraud falls into two broad areas. And maybe somebody can correct me if I'm wrong, but one is billing for services that were not performed, but the other thing is billing for services that are not necessary. And that's a much softer category. And standards of care can help in that area. But, I had a personal experience recently at a very bad time in my life. I was told I needed open heart surgery for valve replacement. And I did not receive that very well. Fortunately, a friend of mine who I did not know was a doctor was retired as cardiologist from the Cleveland Clinic. And he looked at my report and said, Jim, by our standards at the Cleveland Clinic, you do not meet the need for cardiac or valve replacement surgery. Just looking at the quantitative numbers on the test.
Right.
So
yeah, I wouldn't put that so much as fraud as sort of like ineffective or low value services, right? Yeah, and which might be worth adding here, so sort of reduction of inefficient or low value strategy.
And sometimes harmful.
Right. That goes actually more in the provider now that I'm thinking about it. Yeah, I think let's put that in provider. But in terms of system strategies, in this context, fraud is really talking about, that bigger billing fraud that you mentioned first, Jim. Is there anything else that's missing here?
I think Julianne had her hand up, and then Chunwei.
I think administration costs. So just being able to make the claims and the payment claims. So admin really has to be addressed. And if I know that this group is not really into the enforcement of the sustainable growth target, but that can actually be adjusted toward the administrative costs too, saying that administrative costs can't go up X amount percentage per year. Because that's one of the main drivers of overall costs. So I'd hate to leave that off.
Yeah, I fully agree with that. And I wonder if, Lee, we changed that first one. So The purpose of the sustainable cost growth target is to have all the payers try to stay within a certain growth per year of healthcare costs. But under a universal health plan with only one payer, I think it looks different than that. I think, you know, having a yearly budget for a universal health plan that whose growth is linked to some economic indicators and grows at a sort of a predictable rate, you know, so the rate of growth of healthcare costs. So that first one really is addressing sort of containing the rate of growth of healthcare costs, and because there would be just one payer under this, that's kind of the idea. So
I see where she brought up the percentage of growth, the GDP. Surprisingly, this doesn't, they don't correlate the same. So really, we'd have to have the metrics based upon you can't raise, and that means providers don't get much more, get paid more percentages as well. So they go hand in hand when we're talking about admin costs going up and then contracting costs going up. So
yeah, so limiting the rate of growth of total healthcare costs to economic indicators to be determined. I don't know what they are, but yeah, but it's limiting the total rate of growth because that creates downward pressure on the system. If you can only grow by so much a year, then if as new innovations come along or more procedures are happening, it puts a little downward pressure to kind of keep costs contained. But there needs to be a system, a strategy for looking at the entire cost of the system and managing the growth of that cost.
Yeah, Chunwei.
I have two comments. First, respond to both Jim and Helen's comment regarding fraud. Yes, in the largely speaking, the two type of fraud. One is the billing for a service not provided, and two is performing unnecessary services. And I witnessed that in early years of Taiwan's national health insurance during my sabbatical leave. I participated weekly 4-hour executive meetings that I get to hear lots of cases. And one of the case, a hospital in performing the national health insurance promoted pap smear in a matter of 1 month, did a surgery on 25 young girls aged between 25 to 30 to remove their ovary. Those girls went to do the pap smear and ends up their ovary being removed. And so that's a huge flaw issues because it turned out those surgery were totally unnecessary. And the hospital did that simply just to get money. So that's just one example. And with the effective health information system, it can reveal the claim and can flag what kind of a claim are problematic. So that's just one example. And then regarding the system strategy, also responding to Jim's presentation, thank you for your wonderful presentation. One area we haven't included here in terms of system is the social determinant of health. To put more specifically, the universal health plan can have the power and resources to encourage Oregonians to be healthy. And so this year, Taiwan's National Health Insurance is starting a new incentive for all residents. The incentive are targeted at those measures, practices such as vaccination that the government advised. And so if you follow through those advice procedures such as vaccinations, you get incentive. And what they did was a very innovative way to have the convenience store participate. So the government didn't have to spend extra money. And the convenience store team up with the government so to provide the incentive point that people who get the incentive point can use those points to purchase the daily goods from the convenience store. That's just one example. But the general principle is the system has the capability to encourage healthy behavior, but without discriminating people's ability to do that. So that has to be careful, that we have to target what kind of healthy behavior are within the control of the people?
Yeah, that's great. Anything else on system strategies?
I think Jim has his hand up.
So the way that Maryland does its global budgeting is that it is statewide. It's not it is hospital by hospital, but ultimately the top number is they estimate that the economy, they base it on economic growth in the state and population growth. And those two factors come up with a top level number. And that is what all hospitals in the state of Maryland have to stay within. So they break it down to individual budgets to individual hospitals, but at the highest level, it's population and economic growth.
Right.
And
right. So that's what I was suggesting for like, yeah, that we use something along those lines for like the total cost of care for the UHP. Yeah. Yeah, exactly.
And the key is that it needs to be simple enough that it can't be gamed easily.
Mm-hmm. Yeah.
Eve.
I think again, and where this gets placed on the priority list is for someone smarter than me, but malpractice insurance remains a major driver of cost, especially for certain types of providers. And I do think that a system strategy around mitigating the cost of malpractice insurance and maybe state purchasing strategies there as well, or state provision of a plan could help with the costs that at least some specialties experience, OB being the top of that list, of course.
Yeah, there should be some mention, of how to, reform malpractice insurance. Right. I'm not sure how to word that, but we could include that as well. Lee, are you adding these or are you just making note?
I can add these here.
Okay.
Do you want me to fully replace this first one with the kind of new phrasing?
I think so, because the sustainable cost, I think that refers to a program that, and then something about malpractice reform, I think, be additional one. Okay. Anything else that we're missing in system strategy? Does anyone think any of these should not be in there or, keep them out? Otherwise, we can just sort of, comment on each of these in the proposal.
Yeah, I think just from a staff perspective, what would be most helpful is if this committee wanted to identify maybe the top 2 in each category that would be prioritized. Because again, I think these are all great strategies and they all work towards cost containment, but a universal health plan is going to have limited resources. So where should it focus its early attention?
Yeah, and Eve says add implants to the second one. So pharmaceuticals, DME, and implantable devices, I would say. I mean, it seems like under UHP, the administrative cost savings would be right up there. And then the pharmaceutical, DME, and implants would be, I would think those would be the top 2, although the rest are certainly important. Implantable devices there.
Oops.
I think Chunwei has his hand up and then Jim again.
I think Jim first.
I just wanted to say that I don't think these are mutually exclusive. And so I'm not so sure
Mhm.
of the need to prioritize them. You know, you can run on parallel paths.
Mhm.
I have a quick comment regarding the administrative costs. For a single payer system, naturally, from the payer's perspective, its administrative cost will be way lower than any private insurers. For example, Taiwan's universal healthcare, its administrative cost has persistently under 2%. But what I want to comment here is with the universal healthcare single payer system, there's a substantial administrative cost saving on the provider side that the system should be able to capture. The way to capture it is through accurate estimation and factor that into the reimbursement, meaning there will be substantial saving on hospitals and good practice clinic, etc., their administrative costs, which that should be captured by the universal healthcare, and that can be translated into a slightly lower reimbursement.
So it sounds like you're agreeing that the administrative cost, though, would be one of the bigger priorities.
It's on both sides. On the administrative side, which naturally will be lower than the insurance company, but the important part is how we capture the big saving that we expected on the provider side.
Mm-hmm.
Julianne.
I think you could actually put administrative costs up with fraud prevention, waste, eliminate redundancies. I think that all actually kind of comes together under the same umbrella. Do you agree with that, Helen?
Yeah, I think so. There's some, so when I think of redundancy, I think of the example, forgive me, somebody made during this conversation about, a procedure or a test or X-ray. Oh, Chanda was talking about which X-ray happens in one location, but because of IT issues, they show up at the office next day and they just repeat the X-ray because they can't find it, right? So there's like redundancy in terms of ordering tests, of reordering studies, about like starting over when people change networks, and then there's like the administrative costs of like having one payer instead of 200, right, where you're just, the billing and claims are separate. And so I think of redundancy in terms of like practice patterns, and administrative cost savings in terms of like the claims processing. But yeah, I mean, they're all, I mean, I think they all are somewhat related.
I think in a single payer system, my gosh, I would love to get to under 2%. That is like unbelievably amazing numbers. The reality is administrative costs really come in when they keep hiring more and more people to do the job at the payer level. So there's going to be one payer, but there has to be some hold down of how much are we going to pay each of those new people coming in to do that job. That's where AI, which I know that's not a favorable option here, but there has to be ways to keep those admin costs down. And to me, that's waste and elimination of redundancy when you're passing. I'm on the carrier side and I see how many bodies it takes to run that one claim of the one member through the system. But I do think it needs to be up there. Like if we had to vote today, I'm putting admin costs right at the top, like because it's such a huge driver.
Yep.
I wonder, apologies, I'm just going to jump in, not raise my own hand because I was calling on people, but I wonder, Chunwei, if you could speak a little bit more. I think you brought up such an important point that I would love this committee to talk about, which is for provider side savings. And you described, and we think about it, especially I think about hospitals and the massive machinery hospitals have around the billing cycle. And I am wondering if you could describe what happened in Taiwan and how those savings were sort of incorporated into the system. I think you intimated that perhaps that some of it, those savings were realized by potentially lower fees being paid to a hospital or to providers. And I think that this is such an important point that I'm wondering two things. One, what happened in Taiwan, and two, how they were able to accurately capture those savings and then sort of make the argument like, well, you have this many fewer FTEs, so we don't think we need to pay you as much, or how that worked out.
Well, the case of Taiwan is a bit different from here. When Taiwan implemented the universal healthcare in 1995, it started without private health insurance. So it started with only a handful of different government public insurance for public employee and public insurance for labor, excluding family members, and public insurance for farmers and fishers, etc. And so they didn't have to deal with hundreds, if not thousands, of payers that we're dealing with. So it started without that burden. But then what I referred to was about a decade ago, there were studies about the administrative costs on clinics and good practice clinics in the US. And the group who did the research, they kind of come up with the estimation of a range, because there's a variation across region and different size of clinic. But the range was somewhere between 10 to 20% of their total revenue. The total revenue of clinics, they spend about 10 to 20% of that in administrative costs, particularly in billing. So this is what I'm referring to. And of course, similarly with hospital is even higher. And there has been case study comparing US hospital with British and US hospital with Canadians for comparable size of hospital in terms of beds. The US billing department usually needs about 10 times or more personnel just for billing. And so the way hospital and clinics do cost accounting is they factor in all those administrative costs, particularly billing, the cost of billing, into their billable items. That means every reimbursement that they negotiate with insurance company, every item of service, billable services include those administrative costs. So this is what I was referring to, how under a single payer system, hospital, clinic, they can have a dramatic saving from having to deal with hundreds of different payer, not just different payer, but even some bigger insurance company, they have hundreds, if not thousands of different plans that come with different kind of payment system and coverage. It's not just the reimbursement rate, but also coverage. That's the variation in coverage, also what makes a private system so expensive in billing. It's not just the payment itself, but to verify what is covered, what is not covered. Even for same insurance company, different plan has different coverage. And so this is what I was referring with the single payer system. We have uniform coverage, uniform payment that dramatically simplify, and particularly a provider can do electronic filing of claim. And then the significant saving should be captured by the universal health care system, the agency. And that's a way to reduce the financial burden, particularly taxation. And in the finance committee, we repeatedly talk about this issue. We haven't had more accurate or thorough estimation of what are those administrative savings. And without considering those administrative savings, it will potentially make the universal healthcare more expensive than it need to be.
Eve.
So one quick question and then kind of a reflection on the administrative costs question. One is the streamlining of quality metrics assumed within administrative costs, or is that something that we need to consider separately? You know, that of course is a part of administrative burden, but it's intended to be more of a value-based care or population health sort of intervention. And then in terms of administrative costs, we're talking about these in a number of settings right now, including, so I'm on the Industry Advisory Committee for Affordability, commissioned by the Oregon Health Policy Board, and we are focusing on administrative costs. And one of the things we talked about in a planning meeting this morning is that reducing administrative burden does not necessarily translate to a reduction in the price of healthcare, because we will still, even with a single payer system, we will still have a number of private entities who are responsible to shareholders or others who are very interested in keeping the difference of the savings of the administrative burden. And so I think in a universal health plan, we do have to look at how is price set. Today, price is set by the provider. And the way that most providers do that is they look at their highest paying contract, and then they set their price a certain percentage above their highest paying contract, because that captures the full revenue. But that's not necessarily how it should be done in a universal health plan structure. I also don't think the prices can be the same across the board, because different providers work in different environments. But how are those prices set? What are the things we consider in maybe modifying from a basic standard fee schedule to recognize the unique expenditures of certain providers? And how do we then ask, we're going to have to force that prices decrease because the administrative burden decreases. Otherwise, it's just profit.
Yeah. Yeah. How would we include that here? I think both those points are important. So, we address the, streamlining the quality incentives in our quality proposal, but I think it is worth mentioning here. It's so like sort of a rational process for price setting. Like, I'm not sure how to capture that sort of to point toward it, that the price setting itself is something that needs to be addressed and adjusted. So how do you have a phrase that you would use, Eve? Is it some like develop a rational process for price setting, or?
Yeah, a rational and centralized process for price setting, essentially just not leaving that with the individual providers anymore to set their own prices.
Right.
But Tony has some really good thinking on this topic as well, so I'll defer to him.
And he has his hand up. Hey, Tony.
Well, I don't have all the problems solved, that's for sure, but maybe some considerations. How we've arrived at higher prices in this country is because of the negotiations that take place and the different leverage points that we have. Perfect example is just the hospitals in a certain area. They're the only provider. And then a payer comes to the table and says, we'll offer you this. And they say no. And then we lose that whole network. And then that negotiation goes up, right? And so, we have incredible inflation in this country because of those different market-based forces that are market-based failures in our system. I do think that in this system as a whole, there would be greater leverage. We've talked about when you have a bulk purchase for pharmaceuticals, you are able to drive the price down further for that product and that commodity. I think in a single payer, and I'd be curious from my reading on this from other systems, is that you could link payment to more of the consumer price index to say, hey, that inflation is going up at this rate, therefore the delivery care technically shouldn't be exceeding that excessively in a certain area. I think the allocation of care in certain areas, we'd want to lean in towards supporting an area like in a rural area or an area that's more challenging to get delivery of services. But we would have greater cost controls in a system that has a greater surveillance across the breadth of our whole state, rather than in these individual different markets. And so I think that that's a really big piece when we talk about total cost of care across the United States, is that we have just an excessive amount of market failures that have led to increased prices because of these failures. So I think that that is a piece of the puzzle that the state, and when we're all in this together, we all stand to lose when the prices go up that much. And so when we're all into this together, we all apply pressures to say that the inflation of that healthcare delivery side should be moderated, is how I envision that.
So we can add to this list, Lee, develop a rational and centralized process for moderating prices. Does that work?
And then Jim has his hand up.
Yeah, I would just add to what Tony was saying. Part of what makes the system in this country so complicated and challenging is because we have these different payers who are all paying different amounts, and providers often don't even know what they're going to receive at the professional level. The mindset is I have to make money here because I'm going to lose money over there. And if we have a standard uniform system of payment and prices, then that should be less of a factor and might be easier to manage.
Yeah, that's what we're hoping to address with the universal fee schedule.
Right.
Yeah.
I might add just, in the ideas of the global payments, like let's just take hospitals. In that it will continue to be a negotiation, right? But it will have, I think, again, a more moderate effect from the hospital systems as a whole and that stakeholder pool, with us as the public corporation of the Universal Healthcare Governance Board, or whatever the title ends up being. Similarly, in certain countries, such as like Canada, it is the provider group that comes to the table and negotiates what's the fee schedule for that coming year. And I think they do it regionally. I'm not entirely certain on that. Don't correct me. But I believe it's per province that they do that negotiation. But again, I think it's a more moderated impact.
Mm-hmm. Okay, that's really helpful. I think Lee's trying to move us along here. In terms of prescription drug strategies, anything missing from this list or anything that people would like to prioritize?
Yeah.
I think it's a very good list.
It looks like Jim and then Julian.
So frankly, I would take off the reference to the PBM. I have a hard time understanding why in a state centralized system you would need a pharmacy benefit manager. In the employer benefits space, we need them to navigate a very complicated and fragmented system. But you're not dealing with a system that is going to be as complicated nor as fragmented, and you ought to be able to set your own formulary, negotiate your own prices, and I don't see that you would need a PBM at all, period.
Yeah, that makes sense to me. Lee, do you want to comment on why that's here?
This is here just because we drew from the recommendations by the PDAB, by the Prescription Drug Affordability Board. And this is one of the elements they had on there. Also, just kind of with the nod to the fact that given the large percentage of the population that has some amount of federal matching dollars, understanding it could potentially be a process, so PBMs might be around, but I'm happy to remove it if the committee feels like it's, excuse me, not a good use of time in terms of a cost containment strategy.
think Jamie has something in the chat which says maybe refine or eliminate PBM in a way that promotes transparency and accountability, which would be another way to say that, or essentially have a single Oregon entity functioning as a statewide PBM, I think is another way that people think about it.
Yeah, I was thinking limit the role of PBMs and develop transparency and accountability, like something, either limiting them because there's only one, or limiting them because most of them go away, or to the extent that they still exist, which they shouldn't exist, but to the extent they still exist, they should be more transparent and accountable. But yeah, referencing that idea that we would anticipate that for the most part, they would no longer be needed, or would be phased out.
All right, I think next Julianne, then Chunwei.
So I'm going to throw a little bit of a wrench on the PBM side of things. We're going to, I would say we would still need the PBM, because you have those high cost drugs that are limited, and you need a PBM to be able to go and get those drugs at the universal pricing. So you would be hiring a PBM to be managing the system itself and overseeing the costs and making sure that the prices that they're able to attain would be different. Like it's almost a way to do a reference-based pricing on it. So in my opinion, we have this connotation of what a terrible PBM is, but we would actually own our own PBM. So it maybe changing the word so people don't get so turned off on it, but we would need a PBM. There's no way around it.
What about what Mimi said about like there'd be like developing like a state level PBM for managing that, like a single state level PBM or something like, is that what you're
saying? That's my argument.
Oh, sorry, Jim. Sorry.
No, absolutely, you could do that, but you still need that pharmacy benefit managing system to be able to review costs, always looking at what drugs have gone on and off formularies, what have gone into generic drugs. Like the evolution of the drug market is so fast and furious that you do need a PBM that could be transparent to say, this is what we're doing, this is how we're doing it. And it can be state owned. I'm going to be honest, from a local carrier right here in Oregon, Providence owns their own PBM. And we contract out, we do other things for high costs, the one high cost drug that's a $2 million drug that one person needs every 7 years. That's how very few people take that drug. We still have to use a third party to go get that. So maybe using a different language, but would need a PBM.
So I think your point is really, really well taken. And so what we have here is like develop PBM transparency and accountability standards, limit the role of PBMs, and develop like a long-term plan for a state PBM. Is there something that we should adjust about that, or would you add or change that somehow?
I think the wording of long-term plan for a state PBM is exactly where you need to be.
Oh, okay. Okay, good. Okay, excellent. Yeah, because your point's well taken. Yeah, thank you. Anything else?
Chunwei.
My comment is also related to PBM, but the issue is broader and bigger than PBM. Under Universal Health Plan, regarding precision drug strategies, a core issue is what and which drug will be covered. And that requires us to build a state formulary. And with state formulary, most other countries with universal health care, the government will do the negotiation and even purchasing. And so the issue goes above, beyond PBM, and we might need a different name for that. We might, under the administrative agencies, there will be a division in charge of precision drug, from developing formulary, updating formulary, and negotiating price, setting price, and contracting, etc., etc. So there will be a whole division. And I suggest we don't use the name PBM, we use a different name.
Right.
because it's bigger than PBM. And all the function of the PBM can be in-house under this division.
Mm-hmm. Yeah, I like that.
Right. Jim and then Tony.
Is it Tony, then Jim, or?
I think Jim, then Tony.
Okay. Well, first off, I very much agree with Chun Wei, but from our benefit plan, we have both a pharmacy consultant and a PBM. So it's the pharmacy consultant that watches what's going on in the marketplace, advises us on trends and stuff, and it's the PBM that does the negotiations for prices. So I just want to kind of make that distinction. I think they both could be brought in-house, but
Yeah, I'll just jump in real quick. I think a single formulary on there, it's like thinking of standards of care, and Helen, you've commented on this about, this is the beauty of what Kaiser Permanente has done exceptionally well, that I think that is in an ideal setting. One, because it allows providers to anticipate and really be clear on what's available, and then having that tiered pharmaceutical as those next steps. What people know, that this is in extenuating circumstances. This is the process I'm going to go through to make sure this is a unique setting for that patient's case, right? I'm in agreement with the discussion on PBMs, in-house transparency, accountability, but you have to have, so I agree with Julianne that, you have to have the skills to have the negotiation with the manufacturer, and with the multitude of different types of drugs that are out there. But I think, perhaps with Joey's comments, maybe we put a rosy name on it or something, like the optimal price negotiator or something of that nature.
Mm-hmm.
I just want to add, earlier I mentioned about the IT system. And actually, Taiwan's IT system for provider actually started with a small scale focusing on precision drug called Pharma Cloud. And with that Pharma Cloud, all providers have access when they are treating patients, prescribing drugs, and they built in the formulary. And that Pharma Cloud is also active, not only preventing redundancy because people have freedom to see multiple providers. So they have access to what the patient has already been prescribed, and it prevent redundancy of drug, but also it's actively warning physician that if the patient has multiple conditions and has been treating with other drugs and with the different specific condition this physician is treating, the drug the physician is prescribing might potentially be interactive with other existing drugs. So it's a very active and effective system that started with precision drug.
Mm-hmm. Yeah. Should that first line read single formulary that prioritizes the use of generics over brand name drugs?
Yes.
I like that.
Cool. Anything else? I can't see if anybody's hand's up. I apologize. Does anyone have their hand up? Nope. Okay. I think, Lee, do you feel like you got enough information for what you need?
Yeah, I think we've got a really robust list here. So thank you all.
What I would suggest is that obviously we'll be putting this together into a proposal that'll go to the board. This will be a proposal for the board meeting. And once it's all sort of assembled into a single proposal, we can send it out to folks on the committee just to make sure that we got it right. But I think we've got a pretty good sense of it here. So you can take a look at it before we bring it to the board, and then it'll come before the board in the April meeting. If you're comfortable with it, you don't need to review it if you don't want to, but we have good to have a chance to sort of look it over one last time, and then we can bring it before the board. is everyone comfortable with that, based on our discussion today, that Lee puts together a proposal for the board? If you're not, how about this? If you're not comfortable with that, please speak up or make yourself known. Do you see anybody? Okay.
Yep.
Okay, good. Okay, great. It's time for a little break. We have just a little bit more to do, but let's take a 10-minute break and come back at 3:10. Great. Welcome back, everyone. We have a couple of quick other issues to address. I'm going to turn it over to Lee to go over the eligibility question that this committee received from our operations committee.
Thank you. And this should be a pretty straight, option A or B kind of decision, really looking for a high level here. So wanted to provide a little context. Eligibility, this has been decided for quite a while, but just noting that a universal health plan would be available to all who live in Oregon, regardless of all these factors. And that includes some of the subcategories that you see listed there, since those can kind of be on the bubble at different times. Next slide. All right, so the question is really specifically regarding enrollment of new members. So folks that are living in Oregon are covered, don't need to worry about that, but we are talking about people who move into the state and are just beginning to have coverage under a universal health plan. So the operations committee has discussed this, and they have put forward a proposal where an individual that is new to the state would enroll via attestation of intent to reside within the state permanently, needing to submit then verification of that within 90 days, but that a simple attestation would get them onto the health plan. Now, a option that was considered and that the committee was not able to decide on, and that actually ties really neatly into the cost containment discussion you all were having, was this idea of, upon this attestation and upon joining the Universal Health Plan, does an individual immediately have access to the full array of benefits, absolutely everything, including specialized fertility, etc., or is there what they term a new member waiting period, during which certain high-cost elective type procedures would not be covered, essentially requiring the person to be within the universal health plan for a certain period of time before some of those are an option. And next slide. Got a few details, and then we'll open it up for conversation. So a little bit more about this phased-in benefit option that the operations committee discussed. They talked about essentially 2 tiers of benefits. Tier 1 would include primary care, urgent care, immunizations, maternity, behavioral health, crisis, and essential pharmaceuticals. So pretty robust set of services that they're saying would absolutely be available immediately, and that there would be certain elements in there to ensure that those with chronic conditions were able to continue receiving the services that they needed. But that there would be a tier 2 that includes kind of the full scope of services, including some of these that might be considered more elective, high cost, etc. This proposal kind of came out of looking at lots of different enrollment models, and this one in particular is similar to what Vermont had proposed for its Green Mountain Care. They did propose as well, there would be some equity exemptions for those that have certain high-risk diagnoses, minors or adults with disabilities. So those folks would not necessarily have that waiting period, but that an otherwise healthy individual moving to the state would need to, be in the state for, say, 6 months before they could schedule some sort of, not totally necessary expensive surgery. So the pros, obviously, there's some cost containment to having a phased-in benefit option. At the board level, And within the Finance and Revenue Committee, there's been a lot of discussion about adverse selection, about people coming into the state, getting an expensive procedure, and then leaving the state. This option would prevent a safeguard against that kind of behavior happening by requiring that actual residency to be, effectively proven through having to wait throughout that period. There would still be access to most needed services, and in particular, because primary care is available, there's the idea that this will encourage folks to make those early connections to their primary care provider and get established within the health system in the way that we would really like them to, which is in a very, wellness forward kind of sense. The cons of this, it is more administratively complex. Of course, anytime that you have exceptions, you have to have a way to track that, and there is some complexity with that. There's some risk that folks moving to the state could be confused by this, and of course, inequities and wanting to make sure that people who have really legitimate healthcare needs are getting those taken care of without this necessarily getting in the way, precluding them from necessary access to services. Next slide, please. And this might actually be it. I know it's a pretty quick deck here. So yeah, what we're asking for essentially is a recommendation that we can bring back to operations regarding option A or option B. Option A being full benefits upon enrollment, as mentioned, administratively simpler, easiest to understand, and absolutely no equity issues if you give everything. The cons, of course, that adverse selection, and there could absolutely be some higher cost at the system level. Option B would be the full benefits after a waiting period. So a bit more budget smoothing, especially if there are large waves of migration into the state. Fostering an early connection to primary care, and of course, ensuring that everybody does have access to those essential services right away. But it does come with the administrative trade-offs and some potential new member confusion. And again, we're talking about new members that this applies to. So this is a relatively small chunk of people. I think the average over the last several years has been about 150,000 new residents into the state of Oregon per year. All right, I don't know if there's another slide here. Nope, just that. So I'll turn it over to you, Chair Blanca.
Okay, thanks, Lee. Yeah, I'll just open it up. Does anyone have questions about the two options or feelings right off the bat about which way you're leaning, arguments for one over the other?
Just before we get to that, I'm just going to read some of the things in the chat because I know you can't see that. So Peter Merritt asked if there had been a cost analysis of the administrative cost of implementing this option, and the answer to that is no, that hasn't been looked at yet. And then a couple, Jamie Osborne said with caution regarding how it might impact agricultural workers and also workers' comp. So, and then I'm just going to go in the order of my screen. So Chun-Wei Chi, you are up.
Okay, before we discuss those two options, one issue I don't know whether we ever discussed before is regarding eligibility related to length of residency. So for example, if we have either migrant workers or corporate workers who were transferred to Oregon for just 2 months or 3 months, are they eligible? And Taiwan has established that any visitors, the non-citizens who come to Taiwan, who intend to stay in Taiwan for 6 months or longer are both eligible but also mandatory, required to join the National Health Insurance. So I use that as a reference. Maybe we need to establish what would be the minimum residency required, or we don't want to have that. I think that's up to discussion, whether we should have a minimum residency or not, and if we do, what would be the minimum length of residency?
If I could just jump in real quick. So the Operations Committee has addressed the topic of eligibility. They have a statutory definition. And due to federal regulations, you can't necessarily require someone to have been in the state, but I'll just say the residency issue has been discussed and voted on by that board. So we're really just looking at these two options relative to enrollment for this committee.
But that
or if I can
create,
jump in, I think what Chun was saying, like, and I think the definition that we're using is 200 days of the year defines you as a resident. It's not a 6 month, but it's 200 days, which is very
That's
close
correct.
to that, just over 6 months. The question is, if somebody claims to have just moved here, so when people are here long term and can demonstrate that. So in your examples, for instance, a corporate worker who was hired to come to Oregon for 2 months would not be eligible. That would not be considered a resident because it has to be 200 days of the year, and they would be temporary. But for people who say that they're moving to Oregon, they once they get here, can they access benefits immediately? And if so, is it the full complement of benefits, or is it a partial complement with the full being delayed till later?
And I will just also add in that seasonal farm workers are also included in that population of people who are eligible. So that was specifically called out in the proposal. So they would not necessarily need to meet that 200-day. Sorry, I'll keep going. Jim, I think you're next.
I'm not sure I have a preference to option A or option B, but I will point out that in the employer-sponsored world, first-year employees generally are not high utilizers. Just takes them a while to kind of figure out what their health plan benefits are before they actually go ahead and use them. So and for what it's worth, department.
Yeah, in this case, it might be different because if you have somebody who lives in another state and they need a specialty drug or an expensive surgery that with their current insurance in their state, they would have an enormous copay, like an enormous, $10,000 they'd have to pay out of pocket. The idea is, would a plan like this encourage them to come here, claim residency, and access that service, and then just go back home?
Understood.
So it's a little different than people moving here for work. It's just like we have to be aware that we may be creating an incentive for people to do that. The other example that came up was knee replacement. Someone's been waiting years for a knee replacement. They're going to have several $1,000s out of pocket costs. Would they claim residency here, come here, get the surgery, and go home? Those are the kind of debates we are having. Under option A, just to kind of clarify a little bit further, what was proposed is if they can access full benefits immediately on arrival, and then they are later found to be ineligible because they left the state after accessing care, or they didn't stay the full 200 days to be qualified as residency, then it said it on the previous slide, but to be clear, the public corporation that runs the plan would seek to recoup those costs. So they'd get a bill. They got the care for free, but then they aren't a resident and they would get a bill and be required to pay for it. So we would seek to recoup costs that were found later to be that they were ineligible for because they weren't truly residents. That's the other way of dealing with it. Go ahead, Mimi.
Next is Tony. Thank you.
Yeah, I'm strongly for option B for a waiting period. And I think the piece that is leaning me towards that is the calculations from Milliman, and with the adverse selection that is in there, and that is a hefty price tag. We will be the first in the country to do this. I think there would be incentives for individuals to consider, rather than spending $25,000 on a knee in their home state, that's a good chunk of money, that there's some considerations for something to come to our state. I think a number of people coming, I think if we put in some considerations for, workers that, bring a lot of value to our economy with seasonal work, and that's an industry that we need. I think we can have some cautions on that. The administrative challenges of recouping if somebody were to leave, I would rather put it up front rather than try and go chase that down the road. And I also think that, at least how I'm seeing this outline, is that the bulk of care is still primary care. Your regular accident or injury or things like that would be largely covered. What we're talking about is high procedures or really expensive drugs that somebody might have that adverse selection and find it attractive to come here. I think we do anticipate people moving to our state for this benefit. In general, and I think we want to keep people that are going to be here that are going to contribute to the taxes that support all of us. But I think having some precautions, preliminary, would be a wise idea.
Thank you. Peter. Peter Merritt, actually. So.
Thanks, Mimi. Yeah, thanks everyone for this discussion. Yeah, appreciate all the perspectives that have been shared. I brought this up in the chat, but I would be interested to know a little bit more about cost analysis of how much it would cost the state to implement an option like this in administrative costs, and if we are kind of taking on a significant burden in staffing and implementing new systems, kind of specifically in the interest of saving ourselves costs elsewhere. I obviously would kind of want to know what the comparison is there and how much we are actually saving if we're going to be investing significantly there. The other thing that kind of came to mind for me is there was an exception that was carved out for folks that might have high risk conditions or pregnancy kind of at the time of moving to the state. And I guess I just wanted to clarify, like, if someone develops a high risk condition during the waiting period after they move to the state, does that kind of qualify them to then obviously kind of skip the waiting period, even if when they move to the state, they didn't have a qualifying exemption? So yeah.
Yeah. And then you have to spend time deciding what those are, right? Like, I think both options have really significant administrative costs. Both of them do. Because in option B, you have to define what would allow you to override that waiting period. And then, it's all, there's going to be appeals and there's going to be, there's going to be a lot of administrative work to define those conditions. And there's always going to be cases where, you get it wrong, right? Like somebody really does need it and they're not trying to game the system. So there's a lot of administration for option B, but the option A of chasing down the costs for when it does happen and then going after them and trying to collect costs, I think both of them require substantial administrative costs. It's really hard to estimate what those are going to be. I think the closest we can come is sort of looking at medical tourism to Mexico, which is pretty enormous. The number of folks who go down there for bariatric surgery or for dental procedures. And there they are paying out of pocket. So it's not free. They're paying out of pocket. It's just that the costs are dramatically lower than they are here. And that is a booming business in Mexico right now. So it is a thing that will happen. In my personal opinion, it's I think this is a principle thing. Like on principle, which one do we think is the right way to do it? Like give everybody benefits right away and then determine their eligibility. And then if they were, misleading us, then we go after them. Or is it that we, only want to give people, a small portion of benefits and then have them wait? I think it's more on principles. I don't think we can accurately estimate costs. But just sort of gut feeling or principle wise, which one do you think is better?
Eve has her hand up next.
Thanks. I feel that a waiting period probably does make more sense. It almost seems though like it should be we already were thinking about having multiple health plans, right? Because of the Medicaid beneficiaries and what they may have access to that's different from what folks who would not qualify for Medicaid would have access to. It almost seems though like another plan because there may be people who are moving to this state who have legitimate needs and you know, maybe there's an opportunity for them to pay a high percentage or higher percentage out of pocket to get something done during that time period. I don't like the idea that you just plain wouldn't have access or would have to pay 100% of the cost of something that you did ultimately need because it was within a waiting period. But I also do think we need controls to limit the incentive to come here just for the purpose of the health benefit. Although I think we will become a state that attracts massive numbers of retirees, and especially early retirees who, you know, are trying to retire at 55, can't afford health insurance, and would like to come here. And so kind of thinking through how we manage that type of immigration will be important.
Yeah, that's a really good point.
Tony.
You know, pertinent to our conversation on IT aspect, you know, I am curious about how much administration this would be. You know, I think if we can implement a card, you know, that just says you're designated as new in the state, and then as a health service provider, you know right there, right? I mean, it's kind of like if somebody comes in and they have one of the CCOs locally, then I know it's that formulary, right? The problem is we have just these multitude of different formularies. We would have one formulary. The bulk of care would be delivered, but if it got into like a procedure or something, then it would be fairly clear for like a surgery scheduler to say, well, no, they are new in the state. So I just think that we can leverage technology for that. The other plug I would make is that this is something that I really think would have a tremendous impact on the calculations for Milliman, and us revising those to be clear on the adverse selection, and that this is a tool which we talked about a couple of months ago about this. I think is a great mechanism here as a policy to reformulate what that calculation would be.
Mm-hmm. Mimi, is anyone else's hand up?
No, I don't see anyone else with their hand up right now.
I just wanted to jump in from what Eve said. Eve, I don't know, something you said made me think, like, I wonder about if we did option B and said your, you know, basic benefits available right away. It's a 6-month waiting period to access these high cost, what we consider sort of more elective services or more expensive services. But if you need them in that waiting period, you access them and you pay for them. And then if it's determined that you do meet full eligibility, you know, at that 6-month mark, and, you know, it was a necessary care and you meet full eligibility, then those could be reimbursed or something like that. But people could still access anything they wanted as soon as they got here. It's just certain procedures, high cost, elective, unsure if it's truly needed, they would automatically be billed for that in that waiting period. And then, you know, we could do something like that that's a little bit in between, where we're not saying you can't have this service, but more like, sure, but you will pay out of pocket for it, and then if it's deemed medically necessary, it would be reimbursed. Yeah, thanks. So Tony and Gabe both said they'd support that idea. And Jamie's got her hand up.
Yeah, I support that idea too. I'm also just going to say, because I'm the person in the room that's supposed to come up with a weird idea, is like, if we expect medical tourism, why not set up an Office of Medical Tourism and grant situations where people can be granted temporary residence in the state and they pay cash because it still probably is going to cost less here. And we just use that to run the administrative costs. Like, we just know it's going to happen and we give them a legal pathway to get it. Like, if we know people are going to come for medical tourism, let's do it. Let's offer it.
I love that idea, except the impact on access. Like if we encourage that, and then Oregonians would lose some.
That's a good point, Helen.
Yeah.
I do love that idea though.
Yeah, it is a great
Oregon
idea.
is the best.
Yeah.
Just keeping it weird.
It's definitely something worth exploring.
I mean, if I may, I would just say that like we could put caps on how much capacity we have for medical tourism. If we did that, the office could decide we can accommodate this much and still provide appropriate access. I mean, that want to get down a rabbit hole, but I think you could manage that.
Yeah.
I think that's
yeah.
a crazy idea, Jamie.
Yeah. It's definitely something to explore. Yeah.
Well, if we recruit more providers that want to practice in a system that's easier to work in, and we build up our capacity that way, maybe that's it.
Mm-hmm. Mm-hmm. I don't hear anyone advocating for option A. Is there anyone who's thinking option A would be the better way to go?
I'm not seeing any hands.
I will admit that when this was first presented to me, my gut feeling was option A, because it seemed simpler and it seems really complicated to build that list of what's necessary and what's not, because those decisions are so context dependent and case dependent. Somebody's going to lose their job until they get a knee replacement because they have to walk for work. Right. That's a little bit more necessary than somebody who's, retired and just would like to, have a better functioning knee. Right. So like deciding whether a knee replacement is medically necessary or not is complicated. And I wouldn't want to be part of the group that has to sort those out of which ones are, the really crucial required stuff and which ones are truly elective. I think that's really sticky business and there's just too many confounding factors. So my gut feeling originally was A. I'm pretty swayed by the arguments you all have made here. But yeah, I just gut feeling, I was thinking A would be better. But yeah, any comments on that? I'd welcome.
Gabe and then Tony.
Thanks, Helen. Yeah, I mean, I agree. I like your instinct about the administrative complexity of B, and I'm not insensitive to that. I think with regard to the whole program, I want to see more simplicity. The simpler things are, the less gaming of the system there is, the less administrative burden there is. But I mean, having this conversation now, I'm having flashbacks to when we had this discussion with Milliman and they were modeling the adverse risk selection. And I was asking them, how do you model that? Like, what is that? What data is that based on by which you think you can predict how many people are going to move here to seek care like this? And I can't remember precisely what they said, but I do remember feeling like it seemed like a shot in the dark that
Yes.
really didn't have great data to model this on. And maybe I'm wrong. Maybe if we do get this across the finish line and open up for business for single payer universal coverage at whatever point, maybe a ton of people won't start flocking here, but that would be more surprising to me than the opposite, which, I think if people do flood to Oregon for the free healthcare, that could tank the whole program right out of the gate. That's my fear, I guess.
Right. And then lower income people who come here would also need to have a job here, presumably, right? And so that might be a limiting factor. And then the higher income people, what somebody mentioned about like the 55-year-old retirees, they'll be higher income. They're going to be paying a lot into the system. Right now, our revenue strategy has them paying a fair bit in terms of income taxes. So I don't know.
Tony.
I was just going to say, I mean, we have some constructs for this. I mean, we have the HERC. We have some tools as far as a review process. We've created a prioritized list in the past. That's a whole nother debate. But there are some means that we can answer this question for that.
Eve.
Yeah, I think where this conversation gets hard, and this harkens back to the days of COVID. We all learned in COVID that cancer surgery is elective. And how many people had their cancer surgeries canceled because it's an elective surgery, and there were some deaths associated with that. It's hard to know what number. But I think we have to have some serious consideration about if we're going to have an exception for kind of these medically necessary high cost procedures without a waiting period, people are going to get diagnosed with pancreatic cancer and move straight to Oregon.
Right.
Because, you know, and so at times it feels inhumane to have waiting periods, but there are reasons for that. And it is a real thing that people end up with life-threatening conditions and seek whatever option they can find in order to get the treatment they need. So these are things that we're going to have to wrestle with. I mean, I don't think in this committee we'll be able to get from here to there, but if we look at option B, I think we need to get a little harsh, it probably, on those decisions in the waiting period, because otherwise we'll be paying for it on the back end.
Mm-hmm. Yeah.
Peter,
Yeah, and in
Mer-
that situation where, sorry, in that situation where somebody moved here with pancreatic cancer, that would be a kind of situation where, like, you can access that care, you will be billed for it, and then be reimbursed at 6 months or something like that. Yeah, to kind of try to balance that. Yeah. I think one more comment. Is Peter the last one?
Peter.
Okay, one more comment, and then we got to move on.
Yeah, I just have a quick question about kind of outside of this consideration of, option A and option B for a waiting period. The requirement for eligibility that we've kind of laid out is that you intend to live in Oregon for at least 200 days out of the year. Is there a kind of operational piece of that would be seeking to like recoup costs that are paid for folks that kind of make that attestation and then don't stay in Oregon for 200
Yes.
days a year? So we're
Exactly.
already kind of like implementing some administrative
Absolutely.
process to recoup those costs that could also be used in this scenario.
Yep, absolutely.
Okay.
Yeah. Okay, so it seems like the overwhelming preference is for B. And so that's what we can give back to the operations committee with a couple of the caveats that we've outlined in the discussion. Thank you very much for that. I want to turn it over to Mimi to talk about our proposals review. Mimi, how much time do you need for this?
Well, I think I was sort of hoping that we could kind of go through them and have people prioritize. I don't know that that's really accessible in the next, 10 minutes or so. But what we can do, I go through them really briefly, kind of down memory lane about all the work y'all have done. And then I think either if it comes upon you immediately or later, if you want to send me an email or some way, reach out to like specific points along the way on some of these proposals where you're like, oh, we forgot something, or no, that should be taken out, or a revision, or what are these big unanswered questions? Where does staff need to do further investigation and or additional topics? So I'll go pretty quickly through this. And then we'll still have time for public comment and to wrap things up. So benefits. That's interesting. This committee decided the plan in alignment with what the Joint Task Force recommend would use the sort of PEB level benefits as a starting point, also with expanded behavioral health benefits. And this, these additional benefits include dental, vision, alternative care, and fertility services. And this came out, there wasn't necessarily a straw proposal, but there was the board voted on a preliminary structure of the Universal Health Plan Governance Board. Next, behavioral health. You actually created two proposals for behavioral health. So the first one, which came through in March, had a list of services to be covered, and then also a list of clinician types that should be able to be compensated for providing care. And then just very recently, in February 2026, had the integration models based upon local resources and capacity, and then that funding stream alignment where not all of the funding streams would come through the universal health plan, and that some should remain distinct, at least at this time, or at least initially. And so thanks everyone for the help with that. And then the idea of that, in addition to sort of that fee-for-service type of payments, that there would still be a way for behavioral health to have those capacity payments, like per member per month. Long-term services and supports. Initially in March of 2025, of course, continuing long-term service and supports for people who qualify via Medicaid, there was a discussion about individuals having an option perhaps to purchase long-term services and supports insurance from other carriers. So some of the, so to kind of keep that in mind, is that's distinct, because sometimes during the evolution of these discussions, there's been a discussion about prohibiting other carriers, but the additional point for this one in March was the possibility of maybe a cost sharing arrangement for limited long-term care services, and that is not, that portion of it has not been fleshed out in terms of a proposal. You all looked at long-term services and supports again in November, and then looking at how other countries were dealing with it, and the work that Oregon has done to allow long-term services and supports, really helping individuals stay in the community. The decision was that individuals who qualify for long-term care would continue to receive those benefits and services through Medicaid and ODHS, and not have that delivered through a universal health plan. Obviously, all of the medical care, routine medical care, and other that those folks who would receive would come through a universal health plan. Eligibility, we were just talking about this. So who is covered? Oregon residents of all ages, Oregon students under 26 who are going to school in other states, out-of-state students attending school in Oregon, people who are in Oregon carceral settings, and who isn't covered, those who work in Oregon but reside in another state, and people who temporarily reside in Oregon, temporarily meaning under that 200-day per year limit, or who travel or visit. There's some caveats, of course, about emergency care and things like that. Primary care payment model, this was a good one. So some of the highlights, 15% of total UHP expenditures to be allocated to primary care. And then the discussion around using that primary care value-based payment model, which really is a multiple types of payment. So prospective capitated payments and some fee-for-service, kind of a way to blend these different options. And then also for some primary care payment, and opt out of that payment model if there are certain circumstances. Hospital payments, global budgets really were discussed in detail, and the decision that global budgets, for hospitals should account for approximately 70% of the total payment, with the remainder being activity-based and or quality-based. And then the idea that there would be a transition to those global budgets over a 3 to 5 year period, starting with a smaller amount of the anticipated payment and then growing. And as people have discussed today, kind of referring to how certainly in different regions of the state, there are different needs. It may be in terms of being able to keep a hospital open in a rural area. It may be much more expensive, much less lucrative. So there might have to be some decisions around regional payment structures, but the idea that critical access hospitals or other designated hospitals would be able to receive higher payments related to those essentials roles and access. And of course, there's still there is a federal designation of critical access hospitals. We haven't really talked about how that might be play into this as well. Quality of care, discussed having it as not a specific laid out quality of care plan, but that how a statewide healthcare quality policy and strategy could be implemented. And really what we heard a lot from you all, simplicity. And again, we talked about this in terms of cost savings, reliability, efficiency, efficacy, and transparency, and then enhances care, still allows for innovation, but reducing administrative burden. And there's a lot of the things about quality of care. I've kind of put the slide in there. Specialty care, again, we talked about this. continuing value, fee-for-service and value-based payment methodologies, and prioritizing those VBPs that have demonstrated financial savings, as we certainly looked at a lot of them, which didn't necessarily do that. Incentivizing the shift of procedures to high-value facilities. In other words, making sure that any type of surgery or procedure is taking place where it should happen at it, and not necessarily at a facility that is sort of overbuilt for that particular procedure. And then the idea of reference-based pricing to prioritize services in alignment with state healthcare goals. And that's a little bit more of that. Making sure to eliminate low value pay for performance models. There was a lot of discussion about, what would happen with the universal health plan to maintain a stable specialty care workforce, because there was concern that if we do this and there is less funding available for specialty care, losing some of those relatively rare types of providers that was still needed in the state. Phew, that was it. All of that work in 8 minutes, I think, which is pretty incredible. I don't, well, if people have anything, they're like, oh yes, I really want to make sure that we talk about this. We're hoping to spend a little bit more time on that. But if you have anything, I think love to hear it, and or sending emails. All of the proposals are still in the proposal form. So there will still be more work will be done on them, but we'd love any direction that you have for now or later.
Does anyone have any thoughts right off the bat? Or again, like Mimi said, you can think about it and send an email to the staff about if we miss something, or if you want to make sure that we emphasize something. We'd love to hear from you.
All right, I think we can move it along.
Excellent. Thank you all again. It is really great to look back at all those proposals and recognize all the work that this committee did. Again, just our deepest appreciation from the whole board and the staff for all your help with that. We have a little bit of time for public comment. The committee received 2 pieces of written public comment. Those are included in the meeting materials. Lou Sinninger wrote in to question Milliman's calculation of expenditures, and Tyson Tucker wrote in encouraging us to work to eliminate ERISA plans as their particular rules and restrictions make it incredibly difficult to access care. And I believe we have 1 person signed up for oral comment. Is that right, Isabel?
Yep, that's correct.
Lou, are you available for public comment?
Yes, I am available for public comment there. So I did send that letter, and I wanted to speak before anyone voted, but I did notice that the issue that Milliman left, which was actually, their report was a real disservice, because what everybody in this meeting was talking about at multiple times was how much savings a universal plan will give us. And that's the part that's very important, but that's the part that Milliman did not cover. Now, whether they were asked not to cover it, I don't know. But that's the important part, and that's the part that needs to be analyzed before we can roll out a universal plan. I don't know, everybody's guessing how much. Well, there's 20 people, there are 25 people in finance in any given hospital, right? That's all they do, or whatever. That's a huge savings that has to be analyzed. And so, before you can put a plan out, you have to know how much savings you're going to have to be able to know how much it will cost. If we don't do that, if we leave it to Milliman, it'll cost more than the system that we have.
Mm-hmm.
because Middleman put PEB plus, right? Some of the Medicaid coverage, and did not consider any savings. So I don't know what we do with that. I enjoyed your discussion today. I thought you all did a very good job. I'm very proud of you all doing it. I'm sorry you have to close up your committee at this time. So thank you very much.
Thank you, Lou. Appreciate it. And I know Lou wanted to provide his testimony before we voted. And since we just have like 5 minutes left, I wonder if I can trouble this committee to do an official vote on two things. Advancing a cost containment proposal to the board is the first one, which would include the 3 sections we discussed about operations, provider issues, and then the pharmaceuticals. Let's just do a formal vote so that we can advance that proposal to the committee. If you are in favor of advancing that cost containment proposal to the board, go ahead and raise your hand.
It'll actually be easier for me to keep track if we just
roll call.
do it as a roll call.
Yeah, do a roll call. Yeah.
The hands get a little confusing on
That's
my
fine.
end, but so Helen Belanca,
Yes.
Chenwei Chi,
Yes.
Peter Addy,
Yes.
Gabe Andine,
Yeah.
Betsy Boyd Flynn,
Also, yeah.
Mike Durbin,
Also, yeah.
Rob Fizette is absent, Tony German,
Oh, yeah.
Eve Gray,
Yes.
Rosemary Hemmings is absent, Julianne Horner,
Yes, please.
Max Kaiser,
Yes.
Jim McGee,
Yes.
Peter Merritt,
Yes.
Angela McCallick. Oh, looks like Angela had to exit. Jamie Osborne.
Yes.
Thank you.
Excellent. And then one more quick vote. This is to vote on the proposals offered to us by the Operations Committee. The question is that we recommend option B in terms of eligibility, to allow initial eligibility to be for basic benefits, and then there'd be a waiting period for the full benefits waiting period to be determined, I would say, by the Operations Committee. So all in favor, let's do a roll call vote.
Helen Belanca,
Yes.
Chenwei Chi,
Yes.
Peter Addy,
Yes.
Gabe Andine,
Yes.
Betsy Boyd Flynn,
Yes.
Mike Durbin,
Yes.
Rob Fizette is absent, Tony German,
Yes.
Eve Gray,
Sorry, yes.
Rosemary Hemmings is absent, Julianne Horner,
Yes.
Max Kaiser,
Yes.
Jim McGee,
Yes.
Peter Merritt,
Yes. Sorry.
Angela McCallick had to leave, Jamie Osborne.
Yes.
Thank you, everyone.
Excellent. Thank you so much. Any final comments before we adjourn?
Tony.
Yeah, I just wanted a tremendous thank you to staff, tremendous thank you to the chair, and to all the board, governance board, and tremendous work. What a contribution of your time, and so valuable. And really, it's been an honor to share this time with everybody on this committee. I just want to offer that this is a starting point. This is a long slug ahead of us. We're just getting started. And what I would offer is that you're all leaders that have insight into this, and a responsibility, I would say, to, if you want this to happen, you got to get out there and you got to be a car salesman, and car salesman's got to be positive, and you got to really believe in it, and you really need to put it out there to people to say, hey, yeah, this is difficult, this is tough. We've been trying to do this for 100 years in our country, and let's be the first state to do it. So if you want some agency, I'm just going to put out as an advocacy group, Healthcare for All Oregon is going to help lead this charge too. So if that's a place that you would find yourself, I would encourage you to come out and join us, because you got a lot of volunteers coming this way, and it is going to take a lot of boots on the ground. So thank you all.
Thanks, Tony. Anyone else with last minute comments?
Chenwei Chi.
Yes, I echo Tony's comment. I appreciate everyone's contribution to this committee, and our work is not done, most of you probably already heard, what will be taking over to integrate most committees' work will be the upcoming transition committee. And so I encourage everyone who are interested to continue to contribute your idea comments to the transition committee, because now they are going to integrate every aspect of the planning of the universal healthcare. Thank you so much.
Yeah. Thanks, Chenwei. I'm so glad you mentioned that. Yes, please participate in the transition committee if you're able with public comment, and then also with our board meetings, of course. We welcome your comments as we continue on this journey. So thank you all so much again for all your help and support, and wish you a good afternoon.
Bye all.
Thanks,
everyone.
everyone.